Thank you, Mario, and welcome everybody. Appreciate your time today. And yeah, I'm really excited to be a part of this, to be a part of the Primary Care Training Consortium, and to have the opportunity to speak with residents. It's certainly one of my passions and something I don't have as much opportunity to do at the moment. So thank you for your attention today. So today's topic is about understanding provider payment models. And we're going to look at a few things that I think are relevant from both just understanding medicine in general, how hospitals and clinics are paid, and then also some information that I think will be really helpful for you all, particularly as you graduate residency and look at career options available to you. So we'll talk a little bit about what to expect in terms of compensation models. We'll talk a little bit about contracts, things to look out for in contracts. And as Mario said, I've worked over the years in a variety of practice models. I did my residency up at Swedish Cherry Hill in Seattle, which was the residency clinic there was a community federally qualified health center, a community health center. So I've worked in that setting for Indian Health Service, so in a federal governmental setting, for Rehoboth, which was a private nonprofit. And then recently started Gallup Community Health, which again aims to be a fairly qualified health center. So I'll have a screen here in a minute that gives you directions for ways to ask questions. But also if things come up, just feel free to unmute and let me know what questions you have. I think the more interactive, the better. I know you guys have a lot going on and patients in clinic and on the floor that you're worried about. So I think the more that we have a discussion, the easier it'll be to take a break from that for a minute and think about this. So this is some of the team here at Gallup Community Health. And again, we'll talk about different practice settings. This is my current one, which is a fantastic job. I just absolutely love it. I'll talk a little bit about that as well. So objectives for today, you should have received this ahead of time. But we'll talk about current models of provider compensation, including RVUs. You've probably heard of RVUs, but what that means practically is something that you don't have to worry about yet, so you probably haven't. And then we'll talk about how to look at different employment opportunities and why you get some, but oftentimes not a lot of education about billing and coding. We'll talk a little bit about why that's important, why you should pay attention, and why that will continue to be important in your so go ahead and zap that QR code with your phone if you can. We'll have a couple of questions that come up via this Slido platform, but this one gives you an opportunity to ask questions. We'll come back to this slide at the end. So this is sort of the post-it board for where to keep questions for the last, well, we'll try to reserve about 10-15 minutes to be able to address questions at the end. So put those there as they come up. And then the first poll question we'll have here. So what practice environment do you see yourself in after residency? So options that we'll talk about are academic centers. That might be like UNM, large corporations, so hospital systems, Kaiser, those kind of big corporate facilities. Smaller private facilities, governmental, and then the nonprofit sector. So zap those answers. Thank you. Give folks just another minute to get those in, and then we'll look at those responses. Awesome. So looks like about the math here is interesting. So quite a few people looking at academic centers or nonprofit. Oh, I think I know. I think because you can select more than one option. And then, sorry. And then some interested also in small private facilities or governmental organizations. And then nobody that wants to work at Kaiser. I like you guys already. All right, good deal. So different practice types. So academic centers, When we think about academic centers, we often think of the really big ones, so UNM or the University of California system. But residency programs, as you guys know, take place in lots of different places. So I think of this really as jobs that incorporate a significant amount of teaching, faculty positions. So that might be at, a small nonprofit, that might be at a private institution. But the way that academic positions are paid does vary a little bit from what that looks in other environments. And you can imagine why. If you're at a place that is on a productivity basis, you're teaching residents, depending on what level of training they're at, they might be seeing a bunch of patients. And if you're precepting a couple residents at a time, then that makes your production look like you're seeing 3 times as many patients. Or you might be working with a single intern, and that might, really skew your productivity numbers the other way. So important to keep that in mind in an academic setting. So large corporations, again, examples might be, Presbyterian, Loveless, some of those large Albuquerque kind of places. But then there certainly are places that are focused on the outpatient setting as well. And then small or independent private practice. It was interesting to see that that not many of you expressed interest in that. And I think that that's a general pattern in medicine. Probably asked the same question 30 years ago. Most of the family physicians in the room would sort of have in mind that they were going to open up their own small practice and manage a business and be kind of a one-stop shop. And now, in fact, as you all know, most people do not end up doing that. They do end up working for a corporation or a nonprofit or an organization of some sort. With that said, I think, don't cross this off the list for at some point in your career. Again, growing my own clinic here in Gallup has been just a really great educational opportunity and a really fun thing to do. So it is not easy because the reimbursement models are really made for big places. There's certainly a lot of economy of scale, but it is also really rewarding. So keep it in mind. Governmental practice. So 2 of the biggest in our area are the VA system and then Indian Health Service. And lots of great reasons to work in one of these settings. Certainly gives you the opportunity to work with underserved populations to really make the most of your training. Indian Health Service has a lot of opportunities that allow practice of full spectrum family medicine in a way that can be hard to find in other practice settings. So I think that that's important to consider. And then there's absolutely a stability component, right? Government jobs are sort of notoriously stable. The benefits are good. Your retirement plan is great. Your health insurance is great. So as you're thinking about starting families or, what do you want to do long term, important to keep those in mind as well. And then the nonprofit sector, again, I think that a lot of our residencies in the state really look to train residents to serve underserved populations and resource poor areas, rural corners of the state, which certainly have significant needs. And so federally qualified health centers fit in this nonprofit realm, but also rural health centers, rural health clinics, and just small clinics that instead of being sort of physician-driven and profit-oriented are governed by a board of directors and focused more around service and around profit generation. That's my little clinic. We're moving to a much bigger clinic in a couple of weeks, which we really need. And so then the other part of the equation is, how do clinics and hospitals get paid? What are those payment models? What do they look like? So in the outpatient setting for clinics, the sort of traditional, again, 30 years ago, how everything happened was this fee-for-service model. And a lot of outpatient medicine still works that way. And so that's the model where, I see a patient, I code my 99214 for their follow-up visit. I do a punch biopsy of a skin lesion that they're worried about. I code that, and then I get paid based on the actual services provided. The advantages to this model are, pretty clear that the work that you do is relatively well related to the amount of compensation that the facility receives. The downside, I think, at least in my head, the main downside is that it really does reward intervention and reward things that, procedures, things that sometimes are totally necessary for a patient, but sometimes what they really need is to sit and talk with their doctor for 15, 20 minutes, 30 minutes. And so there is at least the concern that physicians might be inclined to do more procedures, take more of those biopsies, do more joint injections than they might if they were being reimbursed differently. So that is fee for service. The prospective payment system, or PPS model, is what you'll find in federally qualified health centers, places that get a set per visit rate, sort of no matter what happens within that visit. I think the advantage there is, again, that you can really focus on what you feel that the patient most needs. There's not that higher weighting for interventions and procedures that you see in the fee-for-service model. The downside is that I think there's a couple. One is that sometimes you are doing procedures that are cost intensive, time intensive. You're doing a ultrasound followed by an endometrial biopsy. If you're just getting paid your standard visit rate, then you are going to lose money on that visit compared to if you were in a fee-for-service model. The other thing that incentivizes is lots of small visits. So this is something that comes up in residency training in terms of agenda setting and keeping to a schedule and limiting what can happen within the confines of a visit. But in the PPS system, from a financial perspective, your best bet is to see the patient, take care of their diabetes, have them come back next week, take care of their hypertension, have them come back next week, take care of their GERD, which is not always what's best for the patient, right? They can't necessarily take off work every week to come see you. They may need to just come once, get the care done. And so again, the ideal payment model will incentivize what's best for the patient. And that's kind of the drawback of the PPS system. Another common issue that comes up in both fee-for-service and PPS models is that with some exceptions, oftentimes you can only be reimbursed for one visit per day. So again, if you have a patient, we live really rurally. If I have a patient that has to drive in an hour to my clinic, if I can see them today and then my diabetes educator can see them and my behavioral health team can see them, way better for the patient, right? Than having to make that hour-long drive, find gas money, find a ride 3 different times. But depending on, again, some details and some situational things, I may only be able to bill for one of those visits. So that's some of the ways that those payment models sometimes fail patients or make things harder for patients than they need to be. Next is a capitation model. And so that really is something that MCOs focus on and put into place, wherein you have a patient panel, you take care of 1,500 patients or whatever that number might look like, and then you're reimbursed from, again, generally the MCO, but from the payer based on the number of patients that you're taking care of. And then the final, which is really quite exciting in New Mexico currently, is this concept of value-based care, which means that reimbursement is based on what's going on with your patients, based on your patient's outcomes. So instead of being reimbursed for doing procedures or for seeing the patient 14 times over the course of the year, you're being reimbursed for how much their A1C improves, or did they get their colonoscopy in time? Are they meeting certain benchmark parameters? And so the advantage there is that if I have a patient, again, that lives a long way away, it's hard to come in, I can just call and have a 3-minute conversation that I don't need to bill. I don't need to worry about that, and see how their sugars look that morning, right? So it gives the provider the flexibility to really do what they feel like is going to best create those positive outcomes in a way that is sometimes not supported by the other payment models. So again, really exciting time in New Mexico. At virtually the same moment, both Medicare and Medicaid are putting in value-based primary care models in the state. On the Medicare side, that's called Making Care Primary, or MCP. And then on the New Mexico side, there's calling it the Primary Care Alternate Payment Model. And they're working to align those quality metrics as much as possible, because one of the things that you run into is that Medicare wants you to report on one thing, Medicaid wants you to report on another thing, Blue Cross wants you to report on a third thing, Presbyterian. So then you end up spending way too much time trying to check the right EMR boxes, and again, not enough time with the patient. So there's this push to align these models, to use them to support and bring additional reimbursement to primary care. And they will both be rolling out. They're both a phased approach, but both starting in July of this year. So we're really excited to jump on those and start to look at what it means to have reimbursement aligned with actual patient outcomes. One of the challenges with value-based care models, right, is that my patients that have a very high rate of baseline diabetes, very high rate of obesity, I may live, a couple of hours from care, have baseline poor numbers and poor health metrics than patients in resource-rich areas where they are generally healthy. And so value-based payment models have to do their best to take into account the social situation, those baseline numbers, so that you're not comparing one community directly to another community, but rather looking at those improvements over time, or comparing to communities of a similar socioeconomic status, of similar characteristics. So the math gets really complicated, but I think it's really cool that both Medicare and Medicaid are trying to make that happen. So hospitals get reimbursed in all sorts of complicated, convoluted, difficult to track ways. But the two sort of overarching things that I wanted to talk about are fee for service, which again is very similar to what we talked about in the clinic setting, where you admit a patient. If you admit a patient for pneumonia, there's a certain fee associated with taking care of that patient's pneumonia. And the other is cost-based, and that is particularly relevant to us because of the critical access hospital system. So in a lot of rural communities, hospitals get this critical access designation, and that allows them to be reimbursed on a cost-based model, meaning that instead of getting X number of dollars per admitted patient, they are getting paid based on the cost to the hospital. And you can imagine where that would be important, because in Albuquerque, maybe you have 2 or 3 ER docs on, and they're seeing 100, 150 patients that come. I don't know. They're seeing a lot of patients that come through the emergency department. In a small place, you still have to staff that emergency department. You still need a provider. You still need nurses. You still need check-in staff, but maybe only 1 or 2 people come through the emergency room overnight. And so that cost-based model is meant to help account for the need to keep services open. Labor and delivery is another really good example, where it takes quite a bit of volume for a labor and delivery unit to be self-sustaining, which is why we've seen a number of them close across the state. And that cost-based system helps to account for some of that difficulty. So find your device again, because we're going to take a step back now and sort of ask ourselves, why all this talk about money? So give me a word or two about why you chose to go into medicine. And if this works right, it'll make one of those, word things where the most common ones are highlighted. What are those called? What are those called, Mario?
Is it a word cloud?
Yeah, word cloud, thank you. I'll give you guys just a couple minutes to get this in. All right, looks like most people, this thing is pretty cool. This is the first time I've used this Slido, but it tells me when people are typing, so that's cool. So thank you. So yeah, relationships, job security, prevention, community, creating change. So lots of reasons why you all went into medicine. Salary is not one of the ones that came up, right? So it is important. You've worked really hard. You've probably incurred a lot of debt. But I think important to remember the reasons that we really got into medicine, and that we could be stockbrokers. We could have made other choices that would have had different financial implications. And this is where we're at. So one of my mentors in residency once told me, you'll know that you chose the right job when you realize that you would do this as volunteer work. So I think when you're looking at job opportunities, this is what matters, right? Is this something that you're going to be excited to get up and go do every morning? Is this something that's going to fulfill you? Is it something that supports your family structure and your work-life balance? So I think those are really the key things to be thinking about. And again, I'm really happy to be able to answer that question in the affirmative these days. I absolutely would, and sometimes do my current job as a volunteer. So compensation models. And by compensation models here, I mean, how do physicians and providers get paid? So the first sort of most straightforward is just a straight salary. They say, great, come work for us. We'll pay you $200,000 a year, and these are the expectations. Meet those, we'll give you your paycheck. So this is more common in academic environments, government, right? So oftentimes VA or IHS, they're going to say, hey, this is our salary. And one of the important things to know about government is oftentimes that just is the salary. Whereas in smaller and private institutions, there's more room for negotiation. Sometimes there is, and sometimes there isn't in the government setting. Sometimes they just pay everybody the same thing coming out of residency. And then we'll talk a little bit about RVUs, and then we'll talk about production-based compensation and why RVUs matter. So first is this long, complicated acronym, these RBRVS. So this is how Medicare determines sort of the price, the value of the work that's being done. And there are three components to go into this, and CMS decides this for every CPT, of which there are, I don't know, thousands. So this is someone's really boring job to think about for every single CPT in the world, what the RBRVS should look like. But there's three components that go into it. So provider work, and that's the RVU component that we'll talk about, practice expense, and then malpractice expense. And then there's this geographic adjustment. So certain regions of the country providing care cost more than others. And so they do factor, Medicare does factor that in. So practice expense is, is this a procedure that you need an ultrasound or a colposcope or a LEAP or some expensive piece of equipment to do? And then malpractice expense, of course, there's some specialties. OB is a good example where malpractice is just much more expensive than in other specialties. And so they do factor that in a little bit. So if you look at how that breaks down, most of it is that RVU, that physician work component. Another big chunk is that practice expense. And then the malpractice is about 4% of what they factor in. So relative value units, or RVUs, again, are that provider work component. And I just pulled some kind of random examples of what that might look like. So these are just your sort of standard office codes and the number of RVUs that are assigned to them. So if most of your, in my practice, most of my visits are 99214. So a lot of them are, established people I've seen before. We have pretty medically complex people. So they're usually that 99214. So I can expect, a little bit less than 2 RVUs per patient visit. And that equation is going to look a little bit different for everybody, but that's a sense of what that would look like. And again, they recalculate this every year. They mess with it frequently. So why does that matter from a compensation perspective? So RVU models so there are either production or shared revenue models, and they can be based on RVUs, so those relative value units, or revenues. You would rather them be based on, in general, on RVUs, because again, that's the work that you're doing. If they're based on revenues, then you get a new inexperienced biller or coder, your revenues go way down, even though you're doing the exact same amount of work. So the RVUs are just more reflective of what the provider is actually doing. So who might want a RVU-based model? So they can be a good fit for mid-career providers who are seeing patients really efficiently, right out of residency. You're still looking a lot of stuff up. You're still, asking a friend about what to do for a lot of patients. And then several years down, that starts to get quicker. Can also, I think, be a really good option for late career folks who actually just don't want to be having to see a patient every 15 minutes, and also don't mind that they're not being compensated as highly there. So I'm thinking about retirement, and so if they're getting paid less, but they actually get to spend more time with their patients, that works really well for them. So sometimes that can be a good fit. Who does it not work well for? So again, if you want to have a lot of time with your patients, be able to spend a lot of time in counseling, that will decrease your RVUs. And then for people who want to serve on committees or be involved in other things outside of just straight clinical care, it's just important to make sure that that's factored in, because anytime that you're taking away from your clinical practice will decrease those RVUs, and you want to make sure that your compensation somehow accounts for that. So value-based, again, this is corresponds to those capitation and value-based payment models that we talked about. So instead of number of procedures you've done or number of patients you're seeing, compensation is based at least in part, and oftentimes these are sort of salary plus models, but at least in part on your patient outcomes. So your A1C improvements, your hypertension control. As per value-based payment for facilities, there can be a lot of difference, even in one practice, among the baseline health indicators of patients. So it can be hard to predict, and it can be hard to make it equitable across providers. So a lot of models are actually kind of a hybrid. A lot of people actually get paid on a hybrid model where they have a guaranteed salary. We're going to pay you $150,000 a year. And then there's an RVU bonus if you're achieving more than X number of RVUs. There's also oftentimes the option for a quality bonus. So that might be a salary plus those value-based patient outcomes. but also sometimes around patient satisfaction or that participation in non-clinical activities. Other things you want to think about. Sometimes these get kind of, I think, underattended to in negotiations and contracting. So how much vacation time and how that's structured. Some places have this paid time off, where some have, a vacation plus sick model. If you're not really expecting to use much sick time, then a paid time off model might be better for you, because then you have the flexibility to use that time for vacation instead of sick time. Holidays, again, this is something that a significant benefit of a government job, right? Because there are a lot of federal holidays, and you will get those off or get compensation for those in the federal system, which can add up if there are 5 or 6 extra days in a federal job compared to something you're looking at in the private sector. So it's an extra week vacation over the course of the year. CME, most places will offer, about 5 days and at least $1,500-ish to allow you to keep up with your CME responsibilities. And then you want to make sure, or at least ask about fees and licenses. So you can see here that over time, excuse me, your fees and licenses can be, $3,000-4,000 a year. So having that factored into a contract can make a big difference at the end of the year. And then just a word on loan repayment, because again, a lot of you are probably thinking, man, I have a lot of loans to work through. Lots of good options for that. And again, New Mexico does a really nice job of it. So National Health Service Corps requires that you be full-time, offers full or part-time options, whereas most loan repayment actually requires a full-time commitment. And for full-time, that's $40,000 over 2 years. Less than full-time, it's half that. New Mexico has a great loan repayment program as well, Indian Health Service. And then you'll hear a lot about this public service loan forgiveness, particularly because there was a lot of skepticism initially about whether or not it would actually be in place long enough for anyone to benefit from it. But it has. People are actually being able to utilize this. So if you're working full-time, so this is 10 years of full-time work, which is quite a commitment, in a government or nonprofit site, and you make 120 payments on your loans over that time, then the balance of those loans is forgiven after that. Those 10 years are 120 payments. So really great, but sort of deferred gratification option. Some potholes and things to watch out for. So this, I think, is really important. So this is pay disparities. And in medicine, these are primarily gender-based pay discrepancies. Absolutely, there are some based around minority status, but they are not as consistent or as dramatic as gender disparities among physicians specifically. So you can see in this model, this is specific to primary care, and women in primary care can expect to make 50,000 less than their male colleagues. And these numbers are account for, part-time status. They account for time away for parental leave. This is actual pay disparity with those things removed. So a word on my experience. This 100% happened to me at my last job. I'd been working as the CMO for about a year when I stumbled across the contract of my male CMO predecessor and realized that he was getting paid $100,000 more than I was. And so I took that to my boss and I said, hey, what do I need to do as well as my male predecessor, who, we were sort of at the same point in our career, similarly experienced. And they said, oh, so sorry, we'll fix that right away. but that didn't fix the 100,000 from the year before I discovered that. So this really does happen. It's a real thing and important to watch out for. So why does it happen? Sorry. Some of it is based around some of the things that we discussed in the models. So female physicians have been shown to spend more time with patients, to spend more time in counseling, to be more likely to serve on committees or do some of those non-clinical activities than male colleagues. So that shift towards value-based compensation is thought to hopefully will have an impact on this and shift some of this. But I think it's important also just to not be afraid to talk to your colleagues. Sometimes people will tell you, sometimes you'll even see it in a contract that you can't discuss payment with people outside your family. I've seen it written that way. That's illegal. You can discuss it. And so it's important to have a sense of, are you getting paid in a way that's comparable to your peers? And I think it's one of those places where there's opportunity for the men in the room to play an important role too. It would be great to have the men asking, what does this look like? I know that there are pay disparities between men and women. I want to make sure that I work in a place that's equitable. Do you have a sense of what that looks like in this facility that I'm considering? I think statements like that really bring that to the attention of the place that you're applying. There are most physicians, particularly soon out of training, will end up in employed or W-2 positions. There's also the opportunity to be an independent contractor or 1099. So those sort of jargon come from the tax form that you have to submit. So employed physicians submit a W-2, contractors submit a 1099, and you might be offered either based on the situation. So employed positions have the benefits of malpractice coverage, your CME time, health insurance, all the sort of standard things that come along with being employed. Independent contractors generally get paid more, and there are some tax benefits. So anything that you're using that's work related can be deducted. But then you're trying to figure out your own health insurance and malpractice. So again, early career, I think most people sort of gravitate towards these employed positions, but at some point you may be considering an independent contractor position as well. Even for a part-time, you're going to pick up some shifts in the local ER that you might do as an independent contractor, whereas you also have your employed position. Some things to look for in contracts. So contracts not infrequently will include a non-compete clause that says you won't work anywhere else while you're employed, and you won't work in the same community for 2 years after you leave that job. That is unenforceable in New Mexico. So just ask them to take it out, and then you're not having to think about it whenever something comes up. Most places, if they're sort of well-versed, understand that it's not enforceable, are willing to remove that. Malpractice, it's important if you have if you have a claims-based policy. So occurrence-based policy mean that anything that any potentially compensatable event that happens while you're employed is covered by that insurance. Claims made means that if someone sues while I'm employed by that employer, that's covered. But lawsuits sometimes take a long time, right? So if I see a patient and then 3 months from now I leave for a new job, a year from now they decide to sue, that wouldn't necessarily be covered under a claims-made policy. So if there is a claims-made policy, it's important that it has this tail coverage that says that it will cover anything that happened while you were at that job. Termination clauses, you just want to make sure that they look fair, that it doesn't say, organization can let you go with 15 days notice, but if you want to leave, you got to give 6 months notice. It should just be sort of fair between the employer and the employee. We talked about discussion of salaries. Provider code, not that kind of coding. Hold on. Okay, provider coding. So maybe just sort of show of hands, how many people feel really comfortable with their billing and coding skills at this point in your training? Awesome. You've got one yes and a couple of kind ofs. How many people feel like they don't really do that right at all? Awesome. So this is just a little bit about why it matters from your compensation perspective. So small changes in coding really add up over time. So if you are undercoding a visit, so if you're coding a 99213 for something that's really, moderate complexity, medical decision making, really 99214 visit, and you do that consistently over the course of the year, that's $144,000 that your practice missed out on. And there are a lot of other, small places where that comes in. So if you're not coding your PHQ-9s or your mini-mental status exam, the different pieces of things that can be added to your regular visit charges, similarly, those add up over time. So it's also really important not to what's called upcode, not to overcode, but to do what's right for the patient in front of you and then document and code appropriately for what you did. And so again, if you're on an RVU-based model, that's going to directly affect your compensation, because if you're coding a lower level visit, you're getting less RVUs for that. At the end of the month, you're going to have less RVUs in your bucket that you get paid that bonus from. So you want to make sure you're doing it right, that you understand it. I think that the AFP has really great resources for coding in the primary care setting. They put out regular updates and bulletins. So that's kind of my go-to. But I think it's one of those things that's best learned sort of as it comes up. So whenever I do a procedure I haven't done before or implement a new screening test, I'm frequently trying to learn that as I go along. So again, be curious about it. If you do something new, talk to your biller or coder or look it up and see if that's something that you should be coding for as well. And then meet with your biller or coder on a regular basis, understand if there are things that they're noticing that that could change the organizational compensation and also your RVUs. And then take a look at those. The practices will generally put out reports and give you a sense of where you are among your peers. So you just want to make sure that you're not way off the mark in either direction. All right, so questions, and hopefully if you put questions on that first slide, those will show up here, but let me know if they're not showing up and let me know what I can answer. And also feel free to unmute and ask directly. Oh, there's something in the chat. Let me see that. My phone doesn't work. Okay, that's fine.
So, Dr. Wangler, I have a question. In terms of getting contracts reviewed, where would someone go to do that? Or who would they turn to?
Yeah, great question. So there are, I think that it would be good to start with your residency program and see what resources they have. Oftentimes there are those resources specifically for residents. The New Mexico Medical Association, Medical Society does offer that service at a discounted rate for members. So if you want to have sort of an official legal review, this is what they do all the time. I think that the Medical Society is a good resource for that as well.
Dr. Wangler, I've got one. I don't know if it went through on my side for the Q&A, but I was just wondering, I wanted to get your thoughts. So the new ACGME guidelines for family medicine programs are really pushing toward empanelment and a much larger focus on quality measures as a way of assessing residents as they go through their programs. So my question for you is, what do you think that this might end up doing for overall, like just kind of the overall landscape for the value-based payment models?
Yeah, really great question. I think it's really nice alignment, right? I think it's a really good focus for residents, again, because those are the metrics that matter at the end of the day. Is how are your patients actually doing? Is their health status improving? How's your panel doing compared to other similar panels? And I think that will provide that training that residents then need to be successful in those value-based models, because it's a significant shift. And so for those of us that trained before that was a big ACGME focus, we're having to go back and rethink about practice and how we might restructure things to better meet a value-based payment model in a way that you guys won't have to. You guys will know it naturally. So I think it's really exciting. I think that primary care really is moving in that direction generally. At least for now, there have been a lot of shifts over the past several decades in priorities, but I think this is a really good one, and it seems to really be taken on in a big way. So I think it's great. What does that look like in practice for you guys?
Just to reflect on it from the Santa Fe side, it's been a little challenging because we're still kind of faced, I think, with a lot of the same pressures for fee for service in a lot of ways that kind of can squash some of those efforts to switch. And that's why I'm actually really glad now we have our accrediting body coming along and saying, okay, this is a requirement for the program, which might help us put a little bit of pressure back on our home institution, just to make sure that we keep that at the center of resident education. Because I think sometimes we are at odds with the health system sometimes in terms of what residents are exposed to and what skills they end up developing to go out and get a job after graduation.
Yeah, absolutely. Absolutely. I think the other, sort of overarching challenge is really that, again, something I think you all are well positioned to be part of the solution for, is that the IT component oftentimes really lags. And so we find all the time that providers are doing that work, but the EMR is not capturing it in the way that then gets sent on to the payer, or it marked in the system for comparison. And so death by 10,000 clicks, right? Like, you don't want to be creating a lot of additional work for the providers where they're having to go in and figure out where to click that they talked about colonoscopy. So how do we best help the technology catch up to this is where the priorities should be. And at least my system is not there yet. I think that I think AI has some really amazing potential to help us get there. I think in 5 or 10 years that landscape will look really different, and capturing the work that's done will be markedly easier than it is now. But right now, I think that we struggle more with collecting the data than we do doing the work. And again, that's really, we don't want to be incentivizing spending a lot of time trying to find the right buttons in the EMR. We want to be incentivizing doing the right thing for the patient. Any other thoughts or questions? All right, so that's my email, val@gallupcommunityhealth.org. So if questions come up or you'd like to talk about any of this further, I'd be very happy to take those questions from you.
Awesome. Thank you very much, Dr. Wangler.
Absolutely. Thank you all for your attention today.